This video is all about our second class of antiarrhythmics, beta blockers. There's 5 different classes of antiarrhythmics, and we can organize them according to class, which is the von Williams classification system. We can also classify them according to if they're rate control drugs or rhythm control drugs. So these drugs can either control the rate of the heart or the rhythm of the heart. The rate control classes are classes 2 and 4, so the beta blockers and the calcium channel blockers. And these medications basically slow the ventricular response. So they don't fix the rhythm problem, but they do kind of help the cardiac output problem that comes along with rhythm problems. So they kind of protect the ventricle from rapid firing, and they act on pacemaker cells. That's what the rate controlled drugs do. The rhythm controlled drugs are classes 1, so the sodium channel blockers, and 3, the potassium channel blockers. And these actually terminate, so stop or prevent abnormal rhythms. So they act on myocytes, and they actually correct the rhythm. The 5th class unclassified, those are medications like digoxin, adenosine, magnesium sulfate, which nurses and doctors call mag sulf. Those can be slotted into different categories, so I'll have a separate video about those. But in this video, we are talking about beta blockers as anti-dysrhythmics. All right, so beta blockers are the chemical class. It's actually, to be complete, beta adrenergic receptor blockers. But there's many different therapeutic classes. Beta blockers are anti-anginals. They are antihypertensives. We can give them for heart failure. Believe it or not, we can give a first-generation beta blocker for symptoms of anxiety. You can give beta blocker eye drops for glaucoma. All sorts of therapeutic classes. So don't be confused when we start talking about the therapeutic classes of cardiac drugs. Just understand that one chemical class can exist in many different therapeutic classes. Now, we're going to talk about, of course, beta blockers and how they exist as anti-dysrhythmics. So we need to understand where pacemaker cells actually live, because these rate control drugs, as we have learned, work on pacemaker cells. So we have our SA node and our AV node. And what beta blockers are going to do is have the impact of decreasing firing of the AV node and decreasing firing of the SA node. Clinically, we're much more interested in decreasing the firing of the AV node, and I'll explain why that is. But either way, we are going to have a reduced heart rate when we decrease the firing through these nodes. Beta blockers can also impact cardiac myocytes. So I'm going to put myocytes in little blue circles here. And if we gave a beta blocker for the purpose of, for example, reducing contractility, then it would hit the myocytes and we could reduce contractility. So the strength of the squeeze with a beta blocker. So that's how they work as anti-anginals. But like I said, here we are very interested in the rate control action of beta blockers. So we're worried about decreasing firing of the pacemakers and decreasing the action potential that travels throughout pacemakers. So generating electricity and carrying electricity. We basically want to reduce the speed of those things to reduce the heart rate. Okay, so let's just review the action potential of a pacemaker cell, meaning how does it even start creating electricity and how does it move electricity. So this is the same pacemaker cell. It's just moving through different phases of its action potential. We start at phase 4 and go to phase 0 and then phase 3. And in this video, I'm just splitting phase 3 up into step 1 and step 2. And not because it exists in 2 steps, but it's just for clarity purposes so that you can really see how the pacemaker gets back to its resting potential. Okay, so I have my pacemaker cell sitting there and the inside of it is negative. It's actually around minus 60 millivolts. That's the resting potential. And I slowly but surely have sodium coming into the cell, and those sodiums are positive, leaking in. The sodium leaking in doesn't make the cell positive, but it does make it less negative. It actually goes to about minus 40 millivolts as a result of those sodiums leaking in. And when the cell reaches minus 40 millivolts, calcium channels open and calcium starts rushing into the cell. And that's what actually causes depolarization, which means it causes the inside of the cell to become positive. And I still have those sodiums on the inside too. So the pacemaker has now fired. It has depolarized in phase 0. In the next step, step 3, I still have the sodiums on the inside and I still have the calciums on the inside. And now because the inside of the cell is so positive, potassiums are very motivated to leave. So potassiums start leaving the cell. And so many positive charges leave the cell that the inside of the cell becomes negative again. So it repolarizes in phase 3. Also, what happens in phase 3 to fully get us back to minus 60, the resting potential, is that the sodium potassium ATPase pumps start working, and so do these sodium calcium exchangers. And the way I think of it is that these channels basically set everything back to the resting potential. They make sure everything moves back to make the cell move into a resting potential again, the minus 60 millivolts. Calcium leaves, sodium leaves, potassium comes back in through this pump. So now the cell is reset and it is back at minus 60 millivolts. That's how a pacemaker generates an electrical impulse. And depolarization, like I said, is the firing. So I'm going to make that really clear here. Depolarization. For a cell to depolarize, you need sodium to move in phase 4. And you need calcium to move in phase 0. That's what makes the pacemaker cell fire. Now, what if we wanted to increase the heart rate? What if we wanted to increase the rate of depolarization? Well, as we know, these pacemaker cells have beta-1 receptors on them, which are adrenergic receptors, which respond to catecholamines. For example, epinephrine could bind there, or norepinephrine could bind there. And epinephrine and norepinephrine binding increase the heart rate. But how do they actually do that? Well, when epinephrine binds, I'll just use epinephrine as an example, could be either epi or norepi. When epinephrine binds, what happens is you get the activation of an enzyme in the cell called adenylyl cyclase. Adenylyl cyclase. And adenylyl cyclase turns ATP into something called cyclic AMP. And cyclic AMP actually increases sodium influx. It increases calcium influx. And therefore, you're going to have quicker depolarization, which is another way of saying a quicker heart rate, because the faster the pacemaker cell depolarizes, the faster the pacemaker cell fires, the faster the heart rate is going to be. So in red, I'm going to write over here, cyclic AMP. That's really where it works. It increases the speed of sodium influx in phase 4, which means we can get to phase 0 faster. And it increases the speed of calcium influx in phase 0, which means we can get to depolarization faster. That's what cyclic AMP does. And that enzyme is activated through the binding of the beta-1 receptor by epinephrine or norepinephrine. So just to make this clear, I'm going to draw an arrow here. When epinephrine binds, this is the action that epinephrine or norepinephrine has. Now, what if you took a beta blocker? If you took a beta blocker, I'm going to block this beta-1 receptor with a yellow beta blocker. Epinephrine cannot bind. So back in my flow chart, I'm going to cross out epinephrine binds. That's not happening with a beta blocker. Definitely not to as many receptors as it wants to bind to, which means we don't have the activation of the adenylyl cyclase enzyme, which means we don't have the creation of cyclic AMP, which means we don't have sodium and calcium influxing as fast as cyclic AMP wants it to, which means we don't have an increased depolarization, and we don't have an increased heart rate. That's how a beta blocker reduces the heart rate. I'm going to draw that all out again, just in a different way to make really sure we understand it. All right, so we have a pacemaker cell, and maybe this one's living in the AV node. Maybe it makes up the AV node, I should say, to be more accurate. And I have a beta-1 receptor sitting on this cell. Epinephrine or norepinephrine, but in this case we'll say epinephrine, when the heart rate needs to speed up, is going to come along and bind to that beta-1 receptor. Because of that binding, the receptor is going to send a signal down into the cell to activate our enzyme, which is, of course, adenylyl cyclase. And adenylyl cyclase makes ATP turn into something called cyclic AMP. And cyclic AMP has the impact of making sodium rush in a lot more quickly than it otherwise would. So we are in phase 4 of the action potential here. The cell is started at minus 60 on the inside. So we started at minus 6, I'll move that a little bit, minus 60 millivolts on the inside. With that sodium rushing in, and now it's rushing in really quickly because of the impact of C-amp, we are moving to minus 40 millivolts a lot more quickly than we otherwise would. And it's at minus 40 millivolts that the calcium channels open. And cyclic AMP makes those calciums rush in a lot more quickly. So here we're at phase 0. And the calcium rushing in makes the cell become positive on the inside. So I'll just put positive there on the inside, which is depolarization. When the cell is positive on the inside, it depolarizes, which means that it fires. It fires off an electrical impulse. All right, so epinephrine is going to equal increased depolarization because of the sodium and calcium rushing in more quickly. And that is going to mean an increased heart rate. All right, now if I gave a beta blocker, I have blocked that beta 1 receptor with metoprolol or whatever the case might be, which means that this signal is not going into the cell like epinephrine wants it to, which means adenylyl cyclase is not getting activated, which means CAMP is not existing as much. It still does exist, part of our normal physiology, but not quite as much as it otherwise would if I didn't take that beta blocker. So not as many sodiums are rushing in. So the cell doesn't move from phase 4 to phase 0 quite as quickly. So at the bottom, I'm going to write slows down. That's the action of a beta blocker. So I'll write that at the top. A beta blocker equals decreased depolarization, which means a decreased heart rate. So this is the same thing that I drew out on the last slide. I've just drawn it out differently so that you can really understand what's happening in the cell. If we block the beta receptor, we are not letting that cyclic AMP be created. And so the sodium and calcium isn't going to rush in quite as quickly as it would if we did have all that cyclic AMP being created. And finally, let's get into a clinical situation where we might actually use these meds. So I'm going to draw out a heart, and I'm going to draw out how electricity normally moves through the heart. So this is the average heart. The electrical impulse starts at the SA node. The atrium are depolarized. They fire, they contract, and then the impulses hit the AV node. That AV node becomes depolarized. The pacemaker cells become depolarized. And now the impulse is sent down to the ventricles, and then the ventricles contract. So it's really the AV node firing that controls the ventricular response. Okay, what if we had a heart that had atrial fibrillation? So this is my second heart. This is my AFib heart. My first heart is a quote-unquote normal heart, and my second heart is an AFib heart, atrial fibrillation. So in atrial fibrillation, we may still have the SA node firing A-OK, and it might actually even be going through the right atrium okay, but there's a problem in the left atrium. We have all sorts of ectopic firings that are not supposed to be happening. There's many different reasons why you can get AFib. That's a subject for a different video, but just understand that's what it is. It's multiple firings in the left ventricle. When those firings are happening, they hit the AV node again and again and again, and maybe some impulses from the SA node are getting through and hitting the AV node, but the AV node basically is just constantly being stimulated. It's constantly being hit with electricity. When it's constantly hit with electricity, it constantly fires electricity down through the ventricles. So it's firing, and it's being hit irregularly, so it's firing irregularly. So in AFib, you have a rapid ventricular rate, and it's because of that AV node constantly being hit with electricity that's being generated in the left atrium where it's not supposed to be generated. And we also have an irregular ventricular rate. If you tried to assess the radial pulse of someone with AFib, you would notice they had an irregular rate. And by rapid rate, I mean the person could be sitting at rest and be between 140 and 180 beats per minute, or basically anything over 100. But it could be as high as 140 to 180, or maybe even higher. So that's what's happening in atrial fibrillation. Now let's look at our AFib heart if we gave this person a beta blocker. Still have the nodes, of course. And this third heart, this is our beta blocker. Well, on our AV node, we have our beta 1 receptor. Put it here, the beta 1 receptor. And of course, this heart still has AFib, so it still has all sorts of firings going on here, hitting the AV node. Okay, if I gave someone a beta blocker, and I'll put it in yellow, I have blocked that beta receptor. What I've actually done is turned off adenylyl cyclase. That's what the beta blocker does, which means we're going to have a decreased cyclic AMP, which means we're going to have a decreased sodium influx and a decreased calcium influx, and therefore a decreased depolarization, which is just another way of saying, in this context, a decreased heart rate. So when we give a beta blocker, that means the AV node can't respond to every impulse. It can still respond to some impulses, but not to all of them. So the AV node is going to keep getting hit. So it's not a rhythm controlled drug. It doesn't change the dysrhythmia, it changes the ventricular response. So the AV node is going to keep getting hit, but it can't fire every time it's hit because we've slowed down the sodium influx and the calcium influx, which is what makes it fire. So it's still going to fire an impulse down to the ventricles, but not every single impulse that it's hit with. So we're going to have a much more reasonable ventricular rate. Maybe in this case, we can get down to 90 to 100. It's still going to be irregular. It's still going to be irregular because we haven't solved the underlying dysrhythmia, but we're going to have a reduced ventricular rate, especially compared to our uncontrolled AFib heart. All right, so let's summarize this. In our normal heart, the SA node is firing. It's in control. The AV node is the gatekeeper. In AFib, that SA node might still be firing, but there's also abnormal firings happening where they're not supposed to be happening, which is in the left atrium. Chaotic firings, the AV node gets hit chaotically. And so we have a rapid ventricular response and an irregular rate. If you took a beta blocker, the AV node can't respond to every impulse because sodium and calcium can't get in quite as quickly because we don't have the C-amp to make it happen. And so we have a reduced depolarization and a reduced heart rate. Let's talk about what medications you might actually use, what beta blockers you might actually use. Well, we split beta blockers up into generations. First generation is meds like propranolol, nadolol, timolol. So they all end with OLOL, and they all tend to start with between N to Z in the alphabet. I say tend to because there's exceptions to every rule, but that's just a general way that I remember. The second generations are meds like metoprolol, atenolol, bisoprolol. Same thing, they end with OLOL, but they tend to start with A to M in the alphabet. And then we have our third generations. And these are medications like carvedilol, labetalol, nebivolol. So these ones, the ending is a little bit different. ILOL, ALOL. Nebivolol doesn't match the pattern, so we just have to memorize that one. And the difference between the three is first generations tend to hit beta 1 and beta 2 receptors. Second generations are what are called cardioselective. They only hit beta 1s. And the third generations hit beta 1s, and they also cause vasodilation by a few different mechanisms, but they cause vasodilation. First line treatment for atrial fibrillation is going to be metoprolol. You'll see it given IV in the hospital. You will see it given also PO in the hospital, but also PO outpatient. So metoprolol tends to be the first line antidysrhythmic for atrial fibrillation. Now let's do a big summary of everything that we've discussed. The SA node and the AV node are the pacemaker tissues of the heart. The SA controls the heart rate. The AV controls how many impulses reach the ventricles. Essentially, it's the gatekeeper. Epinephrine and norepinephrine bind to these receptors that live on these pacemaker cells, the beta 1 receptors. And when epinephrine and norepinephrine bind, they activate an enzyme called adenylyl cyclase. When epinephrine binds, it makes adenylyl cyclase show up. Adenylyl cyclase is the enzyme that turns ATP into cyclic AMP, and that is going to lead to an increased heart rate. And it increases the heart rate because it increases sodium influx and increases calcium influx. And those are the two things that make the cell positive on the inside, which is what depolarization is. It makes the pacemaker cell fire. So if we're not letting epinephrine bind, I'm going to cross it out in yellow, we are not letting this whole pathway happen. We still do get firing. If we didn't, our heart would totally stop, but it really, really slows down the influx of sodium and calcium. So the AV node cannot respond to all the impulses that it's getting hit with, and that's really helpful in a supraventricular tachycardia like atrial fibrillation. Just as a reminder, beta receptors don't just live on pacemaker cells. They also live on myocytes. So you can have a beta 1 receptor on a myocyte. And this is a topic for another video, but if you put a beta blocker there on that myocyte, you would actually decrease contractility, which is one of the ways that beta blockers are an anti-anginal. Most common beta blocker that you will see for a supraventricular tachycardia like AFib is metoprolol. So that is a summary of beta blockers as antidysrhythmic rate control drugs.